I just wanted to say good afternoon, everyone. My name is Kara Jacobson. We want to thank Dr. Kim Muzer for being on with us. I'm the manager of Illume, the Behavioral Health Center of Excellence. Thank you all for joining us today. We will start in just a few minutes as people settle in and more individuals arrive. For those of you who need CEUs or certificates of attendance, you may have noticed we updated our CEU policy. So please just listen carefully. We will put a CEU/certificate form in the chat so we can confirm your participation and determine your certificate needs. If you are having trouble with the form, please email Kizzy. And please remember, you must remain in the training for its entirety to receive credit. And we will repeat some of these instructions throughout the course of the event. So if you're just joining us, we will hopefully answer your questions shortly. So I just wanted to welcome more of our new attendees. Again, my name is Kara Jacobson. I'm the manager of Illume, the Behavioral Center of Excellence. I just want to thank again Dr. Kim Muzer for joining us today, and thank you all for joining us as well. Just a heads up, your video and audio are muted during the presentation. You will notice there is a chat and a Q&A on your screen. Feel free to enter comments into the chat section. If you have questions for our speakers, please enter them into the Q&A. And then we will ask our panelists and Kim later on in the event. We are also recording this event. The recording will be emailed to you later and will be posted to our social media accounts. And I just want to repeat again, that for those that want CEUs and certificates of attendance, please fill out the CEU and certificate form that is in the chat. That will help us to confirm that you did participate and any needs associated with your CEUs. And if you have trouble, please email Kizzy. She has been emailing you throughout this process. And remember to remain in this event to receive credit. You will see this information within the chat throughout the event if you have any questions. And to those of you who are returning from our last webinar event, you may have noticed a significant change. We have changed the name from St. Louis Regional Center of Excellence in Behavioral Health to Illume, the Behavioral Health Center of Excellence. As Illume, we look to spark change in the behavioral health system, and we envision behavioral health systems of care that are accessible, recovery and oriented, and promote well-being. So by providing community-wide presentations and trainings with leading experts such as Kim in the field, we hope to ignite desires for intensive training opportunities and one-on-one consultations with providers for more enriched learning experiences. Illume is more than just one-on-one, one and done style trainings though. We hope honor opportunities like today, light curiosity and deeply inform. And we encourage your agencies to seek further in-depth training to keep clinicians up to fidelity standards so clients continue to receive a high level of care. And we are also working on systems advocacy to promote a more recovery-oriented and evidence-informed system. And certainly not least, we offer awareness and education to communities at large. And we know these efforts cannot be completed just by our department or agency. And with the help of our funders, including Missouri Foundation for Health, our advisory board, and members and partners, we look to promote system change. And so thank you for your patience. We look forward to today, and I would now like to invite Dr. Gary Morris, Director of Illume, to say a few words about our speaker.
Thank you, Kara, and again, welcome everyone. We're glad to have you in today's webinar. Managing a serious illness, especially a mental illness, and also being able to grow beyond that illness to living a life that is so there we go. Sorry about that. I got muted. Living a life that is full, engaged, and meaningful. In other words, to live a life of recovery is one of the most critical issues in mental health. Today, we're fortunate to have with us as the keynote speaker, one of the leading experts in the world on the topic of illness management and recovery. Dr. Kim Muzer, a clinical psychologist, is the co-developer, along with his longtime colleague, Susan Gingrich, of the Illness Management and Recovery Program, or IMR. About 20 years ago, the federal SAMHSA and the Robert Wood Johnson Foundation designated IMR as one of 6 key evidence-based practices for people with severe mental illness. Since then, IMR has been widely implemented, not only in the United States, but across the globe, as it has also been translated into at least 18 languages. And it is supported by a growing number of research studies in terms of its effectiveness. Dr. Mueser, who is a professor at the Center for Psychiatric Rehabilitation at Boston University, will soon describe the IMR program for us. But one of the things I would like you to know about Kim is that he's a Renaissance thinker with a remarkable breadth of knowledge and expertise in the field. In addition to IMR, Kim is a leading expert in other important topics in the field of services for people with serious mental illness, including social skills training for people with schizophrenia, substance use and integrated treatment for co-occurring disorders, supported employment, cognitive behavioral therapy for schizophrenia, cognitive remediation, the treatment of first episode psychosis, trauma and the cognitive behavioral treatment for people with serious mental illness who have also experienced trauma and/or PTSD, psychoeducation and support for family members of persons with schizophrenia. Across these areas, Kim, perhaps more than anyone else, has been a leader in bringing cognitive behavioral treatments to the field of psychiatric rehabilitation. He is also a prolific scientist, publishing more than 400 journal articles and 30 books and treatment manuals. He's also been the principal investigator or co-PI on a number of research grants from the federal government and from foundations, and an editor for multiple scientific journals. There is a depth as well as breadth to Kim's work. I've had the opportunity to work with Kim on several occasions, most extensively in a multi-year grant obtained by Dr. Maria Monroe DeVita and myself that adapted and tested the implementation of IMR within Assertive Community Treatment, or ACT. In those experiences, it has been clear that Kim is a thoughtful researcher, a skilled and sensitive clinician, a champion of recovery, and an optimistic person of caring, good humor, and good cheer, who is a joy to work with. We are very fortunate to have Kim with us today to talk about IMR. And so without further ado, I'd like to welcome Dr. Kim Muzer to our webinar. Kim, thank you for joining us.
Thanks very much, Gary. And thank you, Kara, both of you for inviting me to present and for such a wonderful introduction. I hope I can live up to it. Let me share my screen here to get the presentation going. And there we have it. To begin with the usual disclosures, my only disclosure is that all of my clothes are made by my son, Jacob Mueser, who is a bespoke tailor who lives in Greenwich Village. He actually lives in Tribeca, but he has a store in Greenwich Village in which he sells handmade suits and shirts and things like that. So you're not in quite as good a position to enjoy his handicraft, but perhaps sometime in the future. So to provide a little outline, I'm going to start with a little bit of background to the development of the Illness Management and Recovery Program, IMR, which Gary described slightly, but for those who are not familiar with it, I feel like we need to have at least a brief accounting of its history. I'll then talk about what the IMR program is, and then some about research on IMR. And then I'm going to get into talking about adaptations and unique applications of IMR to either addressing specific populations or particular challenges. And then get a step back a little bit and talk about IMR and the world. What are some of the things that we've learned since the growth of IMR and its translation into multiple languages and adaptations and implementations throughout the world? And with that discussion, I will talk about what we've learned and where we're going. So to begin with, the focus of IMR is on reducing symptom distress, the interference caused by symptoms, and preventing relapses and rehospitalizations. Now, that doesn't mean those are the only things that we're concerned with. But when we talk about illness self-management, those are the specific parameters of illness self-management that are most directly targeted in the IMR program. Of course, we're very interested in helping people improve their functioning and make progress towards personally important goals. But the curriculum is organized around teaching specific information and skills designed to foster illness self-management. The emphasis on illness self-management is in collaboration with other people. And in terms of the history of the IMR program, the reason it came about is that by around 2003, there was abundant research showing that multiple different interventions were effective at improving illness management, but none of these interventions had been all incorporated into a single cohesive model. And so the IMR program was developed in order to incorporate empirically supported methods for illness management into a single cohesive program. Now, early research on illness management, early meaning research done up until around 2002, was summarized in a critical review of the research that included 40 randomized controlled trials of illness management programs. This review identified 5 different components of effective programs for teaching illness management. First, programs providing psychoeducation, or teaching information about the nature of psychiatric illness and the principles of its treatment, using an interactive way that enables people to take the information and to see how it pertains to their own personal circumstances. The second area was medication self-management strategies, which refers to taking medication on a regular basis as prescribed for those individuals who make choices about taking medication. By the way, it turns out that the most effective medication self-management strategy is called behavioral tailoring, which has to do with incorporating the taking of medication into your day-to-day routines so that you are reminded to take it when you go about a particular routine, such as brushing your teeth in the morning and the evening. The third strategy is relapse prevention training. And this is something that's very frequently incorporated in family psychoeducation programs. It's also taught on an individual or a group basis, but it has to do with familiarizing people with the early warning signs of relapse and the episodic nature of most major mental illnesses, and the notion that by tracking or paying attention to the early warning signs of relapse and having an early relapse prevention program, that you can prevent full-blown relapses and rehospitalizations from occurring. Fourth, there was an abundant literature on teaching people how to cope more effectively with stress, as well as persistent symptoms. And last, there was evidence showing that social skills training was effective at improving social support. And the relevance of this is that we know that higher levels of social support are successful in buffering the effects of stress on individuals, and therefore reducing the chances that stress may cause a relapse or rehospitalization. And so IMR was designed in order to incorporate these particular evidence-based strategies into a single cohesive program. Now, in a nutshell, IMR can be described as a step-by-step program that helps people set meaningful goals for themselves, to acquire information and skills to develop more of a sense of mastery over their psychiatric illness, and to make progress towards their own personal recovery. In the IMR program, each person sets individual goals at the beginning of the program based on their own conceptualization of what recovery means to them. Then, over the course of the IMR program, people work towards achieving their goals, which are broken down into smaller short-term goals, which are also then broken down into steps towards those goals, while they learn how to master the curriculum of information and skills taught in the IMR program. Broadly speaking, the goals of the IMR program are to inspire hope about recovery That's why the program always starts with the recovery strategies module, which goes into a discussion of what recovery is and an exploration of what it would mean to the individual if they were recovered, and how would they know they were recovered? What would be the kind of changes in their lives that they would make if they were recovered? Second, it's important in terms of our goal is to prepare people to be informed decision makers about their treatment. As everyone knows, there's a great deal of emphasis placed in a lot of quarters these days on shared decision making when it comes to medication decisions and other treatment decisions for the management or treatment of serious mental illnesses. However, there's relatively little agreed upon curriculum about these illnesses and about the nature of treatments to foster this decision-making process. The IMR program is designed to provide this information in the form of user-friendly handouts that are reviewed and discussed collaboratively in either groups or individual IMR sessions. Another goal, of course, is to increase mastery, the person's mastery over their mental illness. The overall philosophy is to facilitate illness management so that the person has more time to spend working on their goals and enjoying the rest of their lives, and less time to spend on the nature of their mental illness and coping with it and so on. In terms of the IMR Programming Materials, it was first developed with the support of SAMHSA and Robert Wood Johnson Foundation funding. There were multiple stakeholder advisory panels that oversaw and reviewed the development of materials. These panels included researchers, clinicians, clients, family members, administrators. Susan Gingrich and I co-authored the manual. A second version of IMR is available for SAMHSA that came out in 2010. And a range of different materials have been developed to support the implementation of IMR. There is also a third edition of IMR that came out published by Hazelden. Unfortunately, that one does cost money to obtain, but it provides updates on many of the handouts and some of the guidelines for implementing the program. Overall, the program takes generally 10 to 12 months to complete. It can be done in an individual or group format. As noted, people set goals early on in the program and work towards achieving those goals over time with the assistance of the IMR leaders and other group participants when it's offered in a group format. There are 11 different educational handouts that provide information about each of the different topic areas. And the teaching of information and skills uses a combination of different strategies, including motivational strategies, strategies designed to increase a person's interest and motivation to learn a particular area, such as by linking it to a personal goal that they have. Educational or psychoeducational teaching strategies, the teaching in an interactive sort of way, so that the information is meaningful and adapted to the individual's ability to understand and comprehend the material. And cognitive behavioral strategies, which use learning and experiential-based techniques for teaching, such as role-playing and providing a systematic feedback to shape or help people gradually improve their skills over time. Home assignments at the end of each session are collaboratively developed by the participant and leaders. Involvement of significant others, such as family members or friends, or if the program is being offered in a residential service or an inpatient service, it could be other staff members, or it could be other members of an ACT team as well. And the information and skills taught in the IMR program are based on the stress vulnerability model of serious mental illness. Now, we have taken the liberties of modifying this model. This is a model that was in our current modern interpretations of it, most eloquently first described by Zubin and Spring back in 1977, and then refined in particular to bring into focus information processing challenges by Keith Nectarline and Michael Dawson in the early 1980s. And then we've done some modest refinements as well. And in particular, what we did was we added a component that we call recovery management skills, so the overall prevention of relapse and improvement of recovery. And we considered recovery management skills to be focusing on the goals of recovery, to define recovery, work and school functioning, social functioning, independent living, well-being, and the idea of recovery management skills, meaning the person's active involvement in the pursuit of personal goals, their understanding of mental illness and principles of treatment, their involvement in a shared decision-making process, and their development of relapse prevention plans. In other words, these were active things that individuals can do to support their recovery and to reduce the risk of relapses above and beyond the other components of the stress vulnerability model. I won't go into this model in a lot more detail, but very briefly, what the model hypothesizes is that there are biological vulnerability factors that contribute to relapses and rehospitalizations, and that stress can also trigger or worsen these biological vulnerabilities. But there are factors in the environment that can also influence both stress and vulnerability. So alcohol and drug use can increase biological vulnerability. So reducing alcohol and drug use can reduce it, and that becomes a principle of illness management. Medical adherence should be medication adherence. We know that medications can reduce some of the vulnerability. And therefore, for people who make a decision to take medication, taking it regularly can reduce that vulnerability. Recovery management skills can both reduce biological vulnerability and reduce stress. We know that improved coping skills can reduce stress, and that social support can reduce stress as well. And that coping skills and social support interact with one another. When one has better social support, supportive people can help people use more effective coping strategies, and so on. So this is a general heuristic or a guiding model that is used to organize the different curriculum topics that are taught in the IMR program. So there are now 11 modules of the IMR program. You might be interested to know that when it first began, there were 9. And then when we revised IMR, there were 10. And that when IMR was revised again, there were 11. So it keeps growing a little bit. And just to familiarize you a little bit with the content in IMR, it begins with recovery strategies, which involves a discussion of the different ways in which recovery can be defined, which is aimed to get people talking about what recovery means for them, things that they're doing already to support their own recovery, things that they would like to see changed in order to help them move closer to their own conceptualization of recovery. And at the end of the recovery strategies module, which typically takes around 3 or 4 sessions to complete, people have identified their own personal recovery goal and have broken it down into smaller, shorter term goals and steps. And the idea of a personal recovery goal is it's something important that the person would either like to achieve or would like to make significant progress towards over the course of the program. And having recovery goals is thought to serve as a motivating factor for helping people learn more about managing their illness. And once people have goals and they're working towards those goals, you can explore how learning a particular aspect of illness management might be helpful in helping the person make progress towards their goal. The second module is practical facts about mental illness. And there are a number of different handouts for this. There's one handout that is broad-based, and so it could be used for people with a variety of different disorders. The primary disorders focused on in the initial IMR program were schizophrenia, schizoaffective disorder, major depression, and bipolar disorder, although the principles of the IMR program can really be applied to a much broader variety of different psychiatric illnesses, and additional handouts have been created. These handouts about practical facts give basic information about what is known about mental illness, including the symptoms of particular mental illnesses, a little bit about family history, likelihood of developing it in families and so on, a little bit of information about the stress vulnerability model, which is then going into more detail in the next one, but also trying to set positive expectations for the ability of people to learn how to manage a psychiatric illness and to be able to move forward in their lives and be contributing members of society and to have enjoyable, worthwhile, and meaningful lives. All of the practical facts about mental illness handouts identify specific people who have made major contributions to different aspects of the world, whether it's science or the arts or media or things like that, in order to try to combat negative stereotypes that people have about mental illness and the notion that people who have a mental illness can't make significant achievements. The third module is about the stress vulnerability model. And we think this is very useful because it provides people with an overall conceptualization of the nature of their illness and of the factors that can affect it. And these different factors, of course, are addressed in the IMR modules. That is the focus of the program. The fourth module focuses on building social support. This module, more than any other, incorporates social skills training techniques into it, although skills training techniques can be used in the other parts as well. There probably isn't enough social skills training on its own to lead to major improvements in building social support, but it's certainly a start. And what it does is it involves helping people explore who are supportive people to individuals in their lives and how could they increase their support and their connection to others. Fifth one focuses on using medication effectively, and it talks about advantages and disadvantages of medication, and people make decisions about using medication. And then for people who choose to continue using medication, because it's usually, IMR is usually given to people using medication, it goes through different strategies for taking medication consistently. The sixth one addresses drug and alcohol use, talks about the high sensitivity of people with psychiatric illness to the effects of drugs and alcohol. It normalizes drug and alcohol use, such as for coping reasons or socialization or recreational reasons, but also involves people in making a decision about whether continuing to use substances is to their advantage or whether cutting down or stopping might help them in terms of their the management of their psychiatric illness. The seventh one focuses on reducing relapses, and I've talked about the rudiments of a relapse prevention plan already. The eighth module focuses on coping with stress, and in this we teach 3 different stress management techniques, such as relaxed or slow breathing, progressive muscular relaxation, and the use of imagery, with the idea of people tailoring or developing their own strategy or strategies for managing stress. The ninth one focuses on coping with problems and persistent symptoms. This is a very rich one because it goes through the whole gamut of symptoms, ranging from negative symptoms to psychotic symptoms to anxiety and depression, and describing practical coping strategies for each of those. The 10th one is focused on getting your needs met in the mental health system. And so this is aimed at helping people look at the mental health system as a set of potential resources and what might be the resources that people need in order to address their needs. And then the last one is healthy living. This gets into issues of diet, weight, exercise, and things like that. So IMR has been provided in a wide range of different settings. It has been most often provided in outpatient community mental health centers, like places for people. It's been provided in inpatient hospitals, such as both short-term and long-term treatment settings. It's been provided in programs for people with intellectual disabilities, as well as for programs for people who are involved in the criminal justice system, either in prisons or in jails, or for people on parole, for example. It's been implemented in vocational programs for people who are interested in work, and it's been implemented in homeless shelters as well. Some of these we'll get back to in a little bit of time. These are more programs where it's been implemented. I think for the sake of time, I'm going to skip that one because several of those we will go into as well. To give you a little bit of an update on controlled trials of the IMR program, there have been 10 randomized controlled trials conducted in 6 countries. 3 of these randomized controlled trials were conducted with very strong implementation, defined as at least 50% of the people in the IMR program receiving a significant proportion of IMR services. There are two trials, randomized controlled trials that had relatively weak implementation. There were two others that evaluated IMR when implemented on an assertive community treatment team. One of these studies being the one that Gary had mentioned earlier, that he and Marie Monroe DeVita obtained. And then there's been some other RCTs evaluating different adaptations of IMR. I'm going to walk you through some of these findings. The randomized controlled trials with strong implementation were done in 3 different countries, one in Israel, one in the United States, New York City, and one in Sweden. And all of these studies compared group-based IMR with usual care for people with a severe mental illness. Total sample across the 3 studies was 354. Careful attention was paid in all the studies to the supervision of practitioners providing IMR, to the fidelity of the IMR, to the IMR model, and to engagement of clients and programs. And the intent to treat analyses were conducted on all of the people randomized in these studies. And what they found is that there were greater improvements in illness management skills for participants in the IMR program as compared to the usual care program. There was a greater reduction in symptoms for IMR participants than usual care in studies using blinded assignments. And there were greater improvements in psychosocial functioning in IMR than usual care. There were mixed findings about the effects of IMR on social support. I think possibly because probably there's not enough skills training in IMR to lead to a significant increase in social support. But there's some benefit in the use of support to facilitate coping. There were no differences in the hospitalization rates across these 3 studies, but all of the clients and all of the studies were at relatively low risk for relapse. We know that, that although psychiatric relapses are common, we also know the longer it's been since somebody has had a relapse or rehospitalization, the less likely it is for them to have another one in the future. And so if you start with a group of consumers who are outpatients who have not had a relapse or rehospitalization for some period of time, let's say a couple of years, the chances of any of them having a relapse are relatively low. And so there were relatively low rates of relapse across these 3 studies. It's worth noting that a secondary analysis of a Medicaid database evaluating the effects of IMR on ACT teams in Indiana did suggest that ACT teams that had IMR that consumers on ACT teams that had IMR had lower rates of psychiatric hospitalization. There were also a few studies, a couple of randomized controlled trials that had weak implementation of IMR. One of these is a study conducted by Michelle Salyers in Indiana. The other was a more recent study conducted in Denmark. The first study with 114 veterans with severe mental illness, the second one with 198 consumers with severe mental illness. Both of these studies are notable because they were methodologically very rigorous. They had blinded interviewers, they had follow-up assessments, they all used state-of-the-art intent to treat analyses. But both of the studies had problems in terms of low rates of consumer participation in the IMR program. In the Salyers study, fewer than 25% of the participants were exposed to at least half of the IMR sessions. In the Danish study, it was closer to 50%. But in the Danish study, the average participant in IMR had to wait almost 3 months to begin an IMR group. And I suspect that sets people back. You kind of lose that motivation, hence the expression, you have to strike while the iron is hot when it comes to motivation to participate in a rehabilitation program. So what can we make of these 2 randomized controlled trials with weak implementation? Well, not very much, in my opinion. I think what you can say is that it's possible to meet all of the Cochrane review criteria. For people who don't know what the Cochrane review criteria are, these are a set of standardized criteria used to evaluate the methodological rigor of a randomized controlled trial. And they have all sorts of things such as the method of randomization and whether blinded assessments were done, whether intent to treat analyses were done. But somewhat surprisingly, the Cochrane review criteria do not include the degree of exposure or the degree of participation in the experimental intervention. So you can have what is considered to be a rigorous study in the Cochrane, according to the Cochrane review criteria, but still have very low rates of participation in the experimental intervention. And if there's one thing I know about research and controlled trials on psychosocial interventions, and that is that if you can't get the person into the intervention, you can't do much of an evaluation of its effectiveness. And so the primary thing that we need that we can learn from these studies is that successful engagement in IMR requires active involvement of the whole team, probably the whole treatment team and the whole research team. And that integration of IMR as offered as part of a research study with the clinical services is also probably critical in order to have a successful implementation of the program. Let's talk a little bit about two studies that have looked at implementing illness management and recovery on assertive community treatment teams. First study was really a very small one done by Michelle Salyers, small in terms of the number of teams. There were 4 teams that were evaluated. 2 of them were taught and provided IMR to participants, and 2 of them provided just the usual services. And then there was another study done by Maria Monroe DeVita and Gary Morris that I was also involved in. This study involved 8 teams, 4 that provided IMR and 4 that provided a usual ACT services. The study done by Michelle Salyers unfortunately had a similar problem to the other IMR study that I had mentioned in terms of relatively low rates of participation in the IMR program. So the results were that there were in fact fewer hospitalizations found in the program that received the IMR plus ACT, but no other differences were found. In the study done by Maria Monroe DeVita and Gary Morris, IMR was provided by ACT team members. And in fact, the responsibility for providing IMR was shared across a number of IMR ACT members. And they did succeed in getting higher rates of exposure to IMR, although it was still a little bit less than desired, mostly because when we did this study, we didn't realize that ACT team members of ACT teams, consumers receiving services from ACT teams, needed a longer time to receive IMR than usual outpatients might be. Nevertheless, we also saw in this study a relationship between the number of IMR sessions as well as the number of IMR modules that were completed and greater improvements in illness self-management and functioning. So there were certainly some bright spots in that study. And it also, again, pointed to the importance of being able to have a longer period of time to deliver IMR with people who tend to have greater psychiatric severity. This slide is from Maria and Gary's study, essentially showing that there were differences between teams, between ACT teams, in the number of IMR modules completed, as well as the number of IMR sessions provided. So in addition to the fact that you probably need more time to teach IMR, there may be team factors that have a greater or lesser influence on the success of implementing IMR. There's a paper that Gary recently pointed out to me from this study that gets into some of this from a qualitative nature. So to talk a little bit more in terms of research and then more about some adaptations, IMR was implemented in an acute care setting in Taiwan. It was abbreviated to just a 3-session IMR, so you could really hardly even call it really IMR if it's only 3 sessions. But they focused it on people who were about to be discharged from a psychiatric inpatient setting. And what they reported was that clients in IMR improved more in illness, self-management, symptoms, and functioning. And over the subsequent 12 months, the clients in IMR were less likely to be rehospitalized. And then there was a trial of IMR with an electronic health version of the program in the Netherlands with 60 people, and they compared the electronic IMR with regular IMR as administered in a small cluster randomized controlled trial. So that's 4 sites, 2 per condition. Now, this is a kind of a high bar to evaluate an electronic version. There was some evidence that the electronic version increased participation in the IMR program compared to usual IMR. But the electronic component was still underutilized, with fewer than 50% of clients accessing the program ever, and only 34% being regular users. Now, it is entirely possible that this would be different in the current day and age, and with the implementation of IMR and many other programs through the use of either hybrid approaches or straight electronic or Zoom-based approaches. And we are getting more experience with that. But that was certainly a limitation of that study. The techniques are certainly promising. We're all becoming more cognizant of the fact that e-health and other remote technologies are a practical way of increasing access to IMR and related services for some people, but there are costs, and it can be difficult to engage other people in these innovative technologies. To talk a little bit more about adaptations of IMR, I'd like to go into 3 adaptations in a little bit more detail, especially the first 2. The first one is going to focus on integrated illness management and recovery, which targets the co-occurring of psychiatric illness and psychiatric disorders. And I also want to acknowledge a long time collaborator in this area, who I believe may be in attendance on this call, Sarah Pratt, who provided me with both slides on this, and we've been collaborating on one of the projects that I will briefly mention coming up. The second one is on enhanced IMR, and enhanced IMR refers to the enhancement of IMR to also include or address co-occurring substance use disorders along with psychiatric disorders. And then I'm going to give you a little bit more detail about implementation of IMR in homeless centers. So the rationale for integrated IMR is that there are high rates of medical comorbidity in people with serious mental illness. People often receive inadequate care for physical disorders, which puts a premium on improving self-management, as well as the ability to advocate for oneself when interacting with healthcare professionals. Mortality in people with severe mental illness is mainly due to physical illnesses, and the gap between the general population and people with serious mental illness is growing. I'll show you some pictures with that. There's also strong research that shows that people can be taught physical illness self-management strategies, similar to psychiatric illness self-management. And what IIMR does is it integrates psychiatric and the teaching of psychiatric and physical illness self-management strategies. So this slide shows the increased medical comorbidity in people with psychotic disorders. And unfortunately, the actual medical disorders seems to be missing in this. So it ranges from things such as cardiovascular disease, diabetes, and things like that. This slide shows the difference in the mortality gap between schizophrenia and the general population, rather. And what's depicted here is odds ratios. And an odds ratio is just an indication of how much more the risk is for one group than another group. And what you can see is that over the decades, the people with schizophrenia are becoming even more different. Their risk for dying earlier has been increasing over time. In other words, as there have been medical advances in the treatment of a wide range of physical illnesses, people with schizophrenia and more broadly people with severe mental illness are less likely to benefit from such advances. And therefore, the gap between their health and health of people in the general population actually grows. So integrated illness management and recovery was developed based on IMR to be delivered in weekly group or individual sessions for 3 to 10 months. It includes education about psychiatric and medical problems and how they're related to one another and influence one another. It includes training in self-management skills and assistance with goals and steps towards recovery and wellness. The 10 sessions include the following: recovery. The second one is on the brain-body connection. And there's practical facts on physical and mental health. And then unhealthy lifestyle, or rather healthy lifestyles, using medications effectively, building social support, managing stress, managing persistent physical and mental health symptoms, relapse prevention, and getting your needs met in the healthcare system. Some of these, such as you can see the asterisk about practical facts about physical and mental health and healthy lifestyle. These handouts include information, some information that will be taught kind of as needed. So for example, if the person's not a smoker, you skip the stuff on education about tobacco. A brief history of IMR, because it's been around for a while. There was a request for proposals issued jointly by SAMHSA and NIMH to adapt evidence-based practices for older people. And Steve Bartels, Sarah Pratt, and I worked with the people in the state of New Hampshire to obtain one of these grants. And what we did was we developed, pilot tested, and then did a small controlled evaluation of the IMR program between 2005 and 2008. And then since then, the IMR program has been used in a number of larger studies, a large CMMI, that's the Center for Medicaid, Medicare Innovation, that was formed under Obamacare in Boston, and a health home project in Maryland. There was a major revision undertaken to the program to fully integrate self-management curriculum into it. And then there is an evaluation that was done in the randomized controlled trial in Boston, which is currently being analyzed. And then there is a large PCORI comparative effectiveness trial evaluating or comparing the IMR program with the Stanford Chronic Disease Program in Kentucky and Tennessee, with a projected sample size of 600. This program is ongoing. Sarah Pratt, who may be on the call, is the PI in it. And this program was ongoing before the beginning of the pandemic, and we did some rather challenging but ultimately successful shifts towards to providing both of the interventions remotely. And of course, we are looking back to providing these live sometime in the future. But we have continued to do the study over the past year. And IMR is currently offered in 7 states and growing. What we found from the first study was greater increases in knowledge and symptoms and coping, greater improvements in medication management skills, relapse prevention training, management of symptoms affecting functioning, and involvement in healthcare decision-making. There was a greater propensity for seeking information and better outcomes on diabetes self-management. Diabetes is one of the most common of the disorders, physical illnesses that people with a severe mental illness have. And here you can see changes in hospitalization, the orange group being the IMR group, I'm not sure what color that is, magenta, no, it's not magenta, it's a bluish color for usual care, slightly going up as compared to decreases in IMR. A little bit about the Enhanced IMR program. To establish the rationale for Enhanced IMR, there are high rates of substance use disorder in people with a serious mental illness, with rates of comorbidity generally accepted to be in the 50% range for lifetime alcohol or drug use disorder. Most of the shorter term interventions that we have for co-occurring substance use disorder are of limited effectiveness. And so there's a need to have a longer term education and skills-based program for targeting co-occurring disorders. We know that substance use and mental illness interact with each other and therefore necessitating integrated treatment of each. We also know that motivational enhancement is critical to addressing both the disorders and is clearly built into the IMR program. And so Enhanced Imr integrates the teaching of psychiatric and substance use disorder self-management into a single cohesive program. The Enhanced Imr program was designed for people with co-occurring disorders. Every module and every session provides attention to both of the disorders. And the order of the modules was modified in order to reflect the needs of people with co-occurring disorders. There are handouts available, large print, user-friendly design. The adaptation was sponsored by the Minnesota Center for Chemical and Mental Health, championed by its director, Piper Meyer, and a manual for that is available. To give you a little bit of a flavor of the integration, begins with recovery strategies, which becomes very interesting when it comes to co-occurring disorders, because the concept or the term recovery is very commonly alluded to in both psychiatric illness and substance use disorders, but often has somewhat different meanings. And so we don't tell people what it means. What we do is we provide examples of different meanings of each of those that people have used, and we ask people to define it for themselves. What would be recovery for them? And it may pertain to conventional interpretations of recovery. People may have different definitions of recovery from one versus the other, but it gets the dialogue going of what does recovery mean to you? And what are the kind of changes that you would like to make in your life that would be consistent with your idea of recovery? The second module is then basic facts about psychiatric disorders. And the third one is basic facts about substance use disorders. So there's a kind of a parallel fashion in terms of educating people about both of them. The fourth is the stress and vulnerability model, which we've modified to incorporate substance use disorders at the same level as psychiatric disorders. I'll show you that in a second. Then the fifth one is coping with stress. This is fairly similar to the regular IMR, but it brings into focus the issue of stress and substance use disorders in particular. This is the revised version of the stress vulnerability model for the purposes of the enhanced IMR model. So it has recovery skills in there contributing to reducing stress, reducing biological vulnerability. And you have the coping skills and social support as factors that can reduce stress and medication, and skills for not using substances as factors that can reduce biological vulnerability. And then the outcomes, mental illness and substance use disorder outcomes, which of course interact with one another. We then get into social support. And of course, each of these incorporates social support for the management of the psychiatric illness, but also social support for sobriety. And so that can get into things like AA, other kind of self-help groups, how to explore them, and so on. The seventh one is on using medications effectively, so they incorporate substance use medications. The eighth one is on coping with problems and symptoms, and so this incorporates skills for coping with cravings. Ninth is healthy lifestyles. 10th is making a plan to stay well. We had a lot of discussion, and the concept and terminology of relapse prevention is at least somewhat controversial, if not uncomfortable for some people. So we came up with a alternative way of talking about it that people seem to feel more comfortable, making a plan to stay well. And then getting your needs met in the healthcare system, similar to with IMR. One more a slide on adaptations. This is an adaptation for IMR. The program itself wasn't adapted, but it was an adaptation for how it was implemented. And it was implemented at the Center for Urban Community Services in New York City, which runs a wide range of different services for both the homeless as well as the housed population, including people with major mental illnesses, but also people without. In this, they emphasize the term wellness rather than illness, calling it wellness management and recovery. And there are entire mental health systems that have modified IMR to call it wellness, and we're perfectly fine with it. Thresholds Incorporated in Chicago, for example, refers to the IMR program as the WMR program, or wellness management and recovery. Background in the Iraq War, Susan Gingrich and I sometimes referred to IMR or WMR as weapons of mass recovery, kind of a takeoff on the wellness management and recovery. The program is conducted twice a week in groups for about 40 sessions. There are monthly alumni group meetings. There have been high levels of engagement and retention. There's been progress towards personal goals and illness management. While it has not been evaluated in a controlled trial, comparing people who have participated in the IMR program with people who have not, they've found better housing outcomes, in particular, a shorter time to obtaining stable housing for participants in the program. There are many other adaptations of the IMR program, and I'm not going to go into these in detail, but for people who are interested, please contact me, or you can get a reference or resource list from either me or Gary or Kara that I had sent about the IMR program. One of them is for people with intellectual disabilities, in which the handouts have been streamlined and simplified in much plainer language. And this is important because we know that people with intellectual disability are more likely to have a major mental illness, and therefore teaching them the basics of how to manage their illness and how to understand it and how to collaborate with treatment providers is as critical as it is for people in the general population. And this program is called the Healthy Happy Life class. IMR has been adapted for people with serious mental illness who are involved in the criminal justice system. Morgan and colleagues have written a book called Changing Lives and Changing Outcomes, published in 2018 by Routledge. This program, I would say, borrows heavily from IMR while not being titled IMR, but has many of the same concepts, and also has the advantage of addressing particularly important other concepts such as criminogenic thinking styles and criminogenic behaviors. These are, for example, ways of handling conflict, ways of thinking about things that may increase or predispose people to engagement in criminal activity. And these can be targeted just like any other skill, and are important to address in people with serious mental illness who are involved in the criminal justice system. Vocational IMR was developed by colleagues of mine at the Center for Psychiatric Rehabilitation in Boston, and is aimed at teaching people the basics of illness self-management in the context of their pursuing work-related goals and supported employment or other programs. We already talked about IMR for homeless individuals. IMR has been integrated with cognitive remediation in some studies, and it's also been provided in some long-term hospital settings. And interestingly, IMR has also been evaluated as a core psychosocial intervention in inpatient settings designed to provide a safe place to withdraw people from psychotropic medication for people who have either not benefited from psychotropic medication or who resist or object to taking medication. This is a program that was developed in Norway and is underway in several places in Norway, where they've developed inpatient settings for people who want to gradually withdraw from psychotropic medication and learn how to manage the psychiatric illness on their own. And typical of Norwegian society that really tries to attend as much as possible to individual preferences, they have developed an inpatient setting and program. There's a number throughout the country in which people can participate in this process, which typically takes between 6 and 8 months. This is not to imply that everywhere in Norway looks like this, or that all of these inpatient programs look like this, but this is what it looked like in January of 2018 when Susan Gingrich and I visited it, and there was a lot of snow around there. The interesting thing is that in this particular inpatient setting, where everybody was being gradually withdrawn from psychotropic medications, there was an environmental approach in terms of community meetings. The doctors had breakfast with, the doctors and other staff members had breakfast with the clients every morning. There was a strong emphasis on health and physical activity and exercise. And the primary psychosocial intervention, which, as you can see, the reason I took a picture of this is that you can see from 10 to 11 o'clock, Monday through Friday, is the IMR program. So it is an intensive program, and we saw a number of people, I think 6 or 7 people, talk about their experience going off of the medications and learning IMR and essentially reclaiming their lives. And these were individuals who were eventually discharged from the setting. So it was an extremely unique application of IMR. Okay, so in the last few minutes, let me take a step back to say, first of all, there are a number of other controlled trials of IMR that are underway. And there are some large-scale implementations underway to provide IMR. For example, in Minnesota and New Hampshire, also in Israel and Sweden, and Norway also has a very large IMR program. There have been local and regional adaptations made to the IMR program in order to fit it into the culture and the context of the setting. In particular, the term illness management and recovery is often used to refer to an integrated approach to engaging clients in their own treatment, empowering them by teaching them the basics of shared decision-making and taking an optimistic outlook through recovery vision. So I found it interesting just to see the term illness management and recovery used sometimes to refer to concepts related to the IMR program, but not necessarily to the IMR program itself. And so in some ways, the phrase illness management and recovery has entered the lexicon of common use in many places, so that the original trade name is no longer always recognized. As Gary mentioned, there are many translations of IMR, and because IMR is a kind of an open source format intervention where anybody can take the published versions by SAMHSA and translate and adapt them as needed. There are translations of it that we are unaware of, and implementations of IMR that we are unaware of. There's no central authority that oversees it. So what have we learned in all of the years since the development of IMR? One thing is that we've learned that if you develop accessible, free content about mental illness and its management, that people will access it and teach it and learn it. I mentioned this earlier, that IMR is unique in being a relatively open access intervention. By open access, meaning that people can take the intervention and modify it without fear of repercussions, legal or professional for the most part. Given that there are no requirements or stipulations limiting the nature of adaptations that people might do. Now, permitting local control and adaptation has spurred adoption, but it can also lead to problems or challenges in implementation and uptake, in part because you're not quite sure if the meaning or the essence of the IMR program is the same in each implementation of it. At the same time, embedding the recovery vision and the goal setting into the teaching of illness management does seem to be effective at engaging clients in participating and learning about their own treatment. And at the language of recovery and the process of goal setting in the context of teaching specific curriculum and skills has been a powerful vehicle for enlightening clinicians, clients, and family members. This is a consumer and his mother who introduced themselves to me at a conference that I was at in Bangkok, Thailand. And he explained that he had been introduced to the IMR program. He was somebody living in Malaysia, and we've done a lot of implementation in Singapore, and they have translations in Malay, and they do a lot of work in Malaysia. And he had been introduced to the IMR program at his mental health program in Malaysia, had learned about it, learned about recovery, and now he went around to different mental health centers and to different conferences educating consumers about recovery, and reported himself as doing very well. Seemed very well. He was a very nice guy. What else have we learned? One thing is that in order for clinicians to inspire hope in their clients, they themselves have to be hopeful. And I think that one of the ways that we've seen clinicians become hopeful, you can tell them that there's hope, but it's hard for them to believe it. But if you convince them that there's enough reason to give it a try, and they really make a full-hearted attempt to implement IMR, to follow the guidelines, and to individualize it, and so on. Often they're surprised to see the power of the message of recovery, as well as the opportunities afforded by the educational process that integrates education with skills training, with motivational enhancement, all in the process of helping people take steps towards goals. And so often clinicians become hopeful for their clients in the process of delivering IMR. It's not necessarily something that starts at the very beginning, although it is nice when they have it at the beginning. IMR can provide a common language between clients, clinicians, and families, between inpatient and outpatient services, and even between people of different cultures. IMR is grounded in core humanistic values of recovery-oriented services, with a curriculum and structure designed to facilitate learning and practice. The message of wellness contained within IMR and the normalization of mental illnesses. By normalization, what I mean is the explanation that mental illnesses are common, that people are not alone in having them, that they are not individuals of faults, that lots of people have them, and to no fault of their own, as well as the ability to adapt the methods in the curriculum of IMR has the potential to change the lives of people with serious mental illness throughout the world. Oops. I'm showing you here one of the more unusual adaptations of IMR, and this is the adaptation of IMR to be incorporated into a translation of the IMR program into Arabic. And in the Arabic translation, there is a use of art that is integrated with the educational handouts and with the guide that is used for teaching illness management and recovery to individuals. And then in addition, the IMR program contains separate handouts for family members, as well as a separate group for family members to support a loved one in making progress towards their recovery. And so this, and I can't tell you what everything means here, but this is a picture depicting the process of recovery, of getting into and recovering from having a major mental illness. And you can see these different steps along the way. And in Arabic culture, it's an extremely family-oriented culture where decisions are made, including decisions about the kind of work that a person is going to do, including decisions about the person who they're going to make and they're going to marry. And so the process of illness management and recovery and developing close personal relationships is intricately tied up with the process of finding love and marriage, which are connected to one another in Arab culture. And this is another picture showing the stepwise process involved in both learning how to manage one's illness, as well as connecting with others, finding a mate, and so on in one's life. And so, again, it's an interesting depiction that shows the integration of the concept of recovery and the learning of illness self-management skills in a different cultural context. And there are a couple of articles that recently came out. One that was describing the adaptation of the IMR program to Arab culture, and then a second one that is a quasi-randomized controlled trial that compared one group of people with serious mental illness who received the intervention and another group that received just usual services, showing a better illness management and related outcomes for the people who received the IMR program. To wrap up conclusions, and this may leave us a little bit of time for questions, because I think I am a little bit early. Over the past 15 years, the IMR program has become increasingly used for promoting the vision of recovery through active engagement of consumers, through collaboration with them, and ideally support of others, and the teaching of illness management skills. Research supports the effectiveness of the IMR program at including illness-related outcomes, although many questions persist. The IMR framework has proved to be rich in its ability to spawn adaptations and modifications for different settings and groups. And it can also be argued that the IMR program isn't just for people with a serious mental illness. Much of the information and many of the skills are applicable to helping any person get the most out of their lives. This last comment is based partly on an experience I had. I was in Taiwan about 6 years ago, and I was doing a series of trainings in the IMR program, but also attending meetings in which I was learning about their experience implementing IMR. And I was at one meeting which had kind of multiple stakeholders. There were some consumers, some researchers, some family members. And at the beginning of the meeting, this man who turned out to be the father of someone with a major mental illness began speaking very somewhat loudly and very forcefully, and he was banging the table. And I began to get a little worried that I was in trouble for something, maybe. But instead, when he was translated for me, what he was essentially saying is, IMR isn't just for people with a major mental illness. These are just life skills. Everybody can benefit from these life skills. And I have heard of IMR actually being taught as a basic curriculum for improving the ability of people to cope with stress and move forward in their lives. Probably something we all could have used a little bit of over the past year. So I think from a slightly broader perspective, the framework offered in IMR is something certainly that is useful to people with the major mental illness, but may well be applicable to a broader population of people as well. So with that, let me stop sharing my screen to see if there are questions or how the facilitators would like to organize the time at this point.
I think, Kim, what we'd like to do is first to thank you for that presentation of covering the fundamentals of IMR, the programmatic aspects of it, and the research. And it was particularly fascinating, I think, covering all the adaptations of it, and then the dissemination across the world, and some of the cultural aspects of that, such as we spoke about in Arabic countries, and all that is rich. And I think what we'd like to do is go to our panel and then come back with questions and save that for the last part. And we'll see what other questions come up. But I know I would be a little bit interested, if there's time toward the end, of getting your thoughts about, are there additional adaptations that you see coming or that you would recommend for IMR, either in terms of, for special populations or cross-culturally, or just given the emerging needs in the field. But for now, I was on a other presentation once before where they're able to kind of like stop the main screen and bring everybody up and do a clapping. Unfortunately, our platform doesn't have that functionality, but on behalf of 150 or so people, I want to thank you for your presentation. It was very informative. It gave us a lot to think about. And for now, what I'd like to do is to introduce our panel members. We have two individuals, each who are going to speak for about 4 or 5 minutes. And the first one of those is Colleen Doyle, who's a licensed clinical social worker. And Colleen has worked at places for people, I'm not exactly sure how long, but at least for a handful of years. And during that time, she's had experience as a direct service provider. She's had experience as a supervisor, and for the last 2 or 3 years, she's been the coordinator of IMR services, where she's helped within places for people to train other staff and other teams in IMR, and then to do consultation as well as providing IMR herself. So Colleen, we would be very interested in any thoughts you have about IMR in terms of providing that, or in training, or any other comments you would like to make about IMR today.
Yeah, thank you so much for inviting me to participate in today's webinar. I'm honored to be a part of the panel today. Like Gary said, I'm Colleen Doyle, and I'm the IMR coordinator at Places for People. I've been growing the IMR program at Places for People, and we're currently providing IMR in one-on-one settings, group settings, and as targeted interventions. To date, about 1/3 of the staff at Places for People have been trained in IMR, and over 300 persons served have received IMR services since this role began. We also hold a monthly consultation group for providers. So I have some thoughts here about things that stand out to me in my experience with IMR. I have found it an incredibly helpful tool in having meaningful recovery-oriented visits with persons served. And people who have been trained in IMR report that it has helped them move from the rehabilitative or maintenance services to a more recovery-focused service. I also appreciate that it centers around collaborating with persons served and identifying and pursuing their goals, which drives person-centered treatment. And that you can kind of tailor the curriculum after completing that first module and recovery strategies to help persons meet their goals or to start in a place where they're most motivated to work or to make changes in. When provided in a group format, I've watched the material transform into empowering conversations and peer support. Frequently, persons served provide positive reinforcement to one another in reaching their recovery goals and increasing their confidence. I also appreciate how participants can gain knowledge and perspective from one another and their experiences in the mental health system and in their symptoms and strategies for recovery. The handouts are great at breaking down material such as psychoeducation and coping skills training into a tangible format for persons served and staff to utilize. And they're also written in terms that are easy to understand and identify with, but that doesn't sound judgmental. For example, it might present some different strategies for recovery for persons served and ask, is this a strategy that I already use or that I'd like to develop further? So it presents the knowledge and information and then allows the person served to choose which tools and strategies work best for them. There's also additional IMR practitioner materials that are really helpful, like the IMR goal sheet. The problem solving sheet it's a great skill to teach and vital in so many dimensions of life. The payoff matrix is great in identifying goals. I also appreciate that anyone can be an IMR practitioner. So at Places for People, we've had practitioners who were students, peers, OTs, nurses, social workers, counselors, residential specialists. And as Kim pointed out, it's flexible to different levels of care. So at Places for People, we offer it in therapy services, residential services, ACT, CPRP, ITCD. So it's great for a wide range of settings and populations. As Kim also pointed out in his presentation, that I've also found the different spin-offs of IMR helpful for our agency. So we use the Enhanced IMR on our ITCD teams, and the integrated IMR is great for senior teams, physical health teams, or medically compromised teams. And also the VIMR, vocational IMR, is great for employment specialists. Also, our agency has just adopted several of the ideas of IMR into our standard practice. So the relapse prevention planning has been incorporated into some of our annual paperwork, as well as pieces from the knowledge and skills inventory into our annual assessments. And then I just have some thoughts that I collected from persons served, what they have to say about IMR. So it helps me get better in understanding what I'm dealing with and what I can do to make things better. It helps me with my anger. I think it's great. I get to hear about what other participants have to say and their inputs. The handouts are good. I like discussing topics related to my mental health. It's educational and increases my awareness. And I learn a lot from it. Staff also shared some of their thoughts with me from our consultation group. It boosts my confidence in providing therapeutic interventions. It's been a lifesaver in providing material to discuss with persons served. Introspective exercises assist with getting a better idea of person-served values and preferences. Materials assist in engagement and enable me to address my person's priorities and work towards recovery, which positively impacts the whole person. Module 1 is a great way to get to know what people are interested in working on and developing goals. So those are some of my thoughts about IMR, and thanks again for having me today.
Thank you, Colleen, for your comments. And I believe you shared a lot about how an agency can adapt IMR and use it in a lot of different ways. It was particularly striking and important, I think you said, about how it can be such a great platform for recovery and for facilitating peer support, and can be used in so many different ways. So thank you for that, and thank you for all the good work you're doing with IMR within Places for People. And now I would like to introduce Amanda Levine Rodriguez. And Amanda, the reason we're all here really is to be able to be of service to people who are facing mental health issues. And Amanda is someone who's received IMR services from Places for People. And Amanda, thank you for being here and being a part of this webinar and being willing to share your thoughts about IMR. So we'd be interested in any comments you'd like to make.
Okay. When I first joined Places for People, I was in a very dark place. I didn't know what my mental illness was even was. I just knew I had problems and I didn't know how to deal with them. I was very lost and did not know how to cope with the things that were going on with me. I'm bipolar and major depressive disorder. And I spent a lot of time just in a very dark place. When I first got introduced to IMR, it was so easy to be able to talk about things because it was kind of laid out in a way that I didn't have to come up with something to tell you what was wrong. I could, go through this program and find a way to make it work for me in my life. It wasn't just do this and do that. It was, here's some skills. Here are some things to look at in your life, how this is affecting you. It helped me figure out some triggers and how things began when I would go into a depressive episode. So these skills have been a lifesaver for me. I have gained a quality of life I never had before in using this. And I am just so thankful for that program, because before it, I like I said, I didn't have really a quality of life, but with it and with going to the groups and following the guidelines and just being able to find these pieces of myself that I didn't even know, that I didn't know that coping was even a possibility for me. I didn't know how to. I didn't have the skills necessary. And the IMR program helped teach me that. It helped me learn about myself. It helped me learn what worked for me. And it's just been a very, very positive experience in my life. It also helped my family understand the things that were going on with me, because they didn't know how to handle the depression and everything. It was just ignored, just, she'll be okay. She'll be okay. And just give her time. And so they didn't know how to react either. So, but going through the IMR program, it helped my family too. It helped them understand me better. It helped me understand myself better and find skills or learn skills that were able to boost the quality of life, and that I just never thought was possible before.
Well, Amanda, thank you for sharing all that. And I think your comments illustrate how IMR can really provide people a structure to be able to gain knowledge, gain understanding, gain skills, and have their life go in a better direction. And we're so glad that for you, that's helped you get from that dark place that you used to be at to a positive quality of life. And you're being a part of making that more possible for other people by sharing your story. So thank you so much for being here and for your comments. And so glad to hear about how things have changed for you.
Oh, thank you. And thank you guys.
Yeah. Well, again, I'd like to thank both Amanda and Colleen for their comments. and also Kim for his keynote. And what we would like to do at this point is to transition into a general question and answer. Those questions could be directed to Kim or Colleen or Amanda if they're available and open for comments. And to facilitate the question and answer period, I'm going to introduce Julie Blanco. Julie is the Director of Training for Illume, the Center of Excellence. And Julie's been fielding some of the questions that have come up through the chat. Julie, would you like to steer us forward in this part of the conversation?
Yeah, I would. Thank you very much, Gary. And thank you, Kim and Colleen and Amanda and everybody for putting in some really good questions. I think start with maybe one of the easier ones, maybe, we'll see, is for you, Kim, but also maybe for Colleen, about what are some of your thoughts on the best ways for clinicians to learn and get trained in IMR?
Great question, Julie. There's a couple of approaches to getting trained. One is, it's of course wonderful if you can get a trainer, somebody who can come in, do an intensive training. Typically, we do a 2-day training, although you can break it out into more sessions for a briefer period of time, and then to get ongoing supervision. There may be somebody who has a training capacity at places for people who can do it, or you may need to bring in somebody to do it. But we do think that a training is a useful way to begin, but it's not really the only way to begin. There is a manual, and the manual includes, of course, the handouts and lots of guidance for clinicians, providing background and things like that. I do think, and then there are also a series of, there's an introductory videotape, there's a series of training videotapes that can be obtained from trainers that give examples of teaching for each of the original 9 different modules of IMR, and that can be useful. I think a motivated a clinician can get the materials, can read the materials, and could begin actually just following the manual, using the materials. It helps if they have some background in psychoeducation. It certainly helps if they have some background in CBT, but it's not absolutely mandatory. I think there's another couple of possibilities. If there's an IMR group, one good way to learn it would be to co-lead a group with an experienced IMR leader. That way you can take turns leading sessions as the person becomes familiar. You can prepare for it by reviewing the materials. You can debrief afterwards. And that kind of assisted learning by doing is very useful. In the absence of an ongoing group, a motivated person, if they're able to find somebody who knows IMR, I would encourage them to schedule weekly supervision meetings to go over how sessions are going. If they're able to audio tape sessions and have an experienced person listen to some of them, that can be useful as well. So there's a broad range of different options out there because there's no official designation of what the only way to receive training is. I think you don't have to do it any one particular way. It really depends on what your access to different resources and expertise is.
And then another question about fidelity. What do you think are the top 2 or 3 fidelity issues for practitioners to really focus on? One person noted that sometimes they observe that in the group format, it doesn't always, the exercises aren't always getting tied back to the participants' goals sometimes. And that, just organizationally, how do we monitor fidelity the best?
Right. So organizationally, there's really 2 approaches to monitoring fidelity. One of them is the IMR fidelity scale, which is really designed to evaluate the fidelity of an overall program to the principles of IMR. It's not aimed at individual clinicians providing IMR, but rather an overall program. And it takes a couple of days to implement, although you could implement it, from a self-study perspective. And that is the version of the IMR fidelity scale that's included with the toolkit that you can download from SAMHSA. More recently, there was a individual competency scale developed in order to evaluate the competency of individual clinicians implementing IMR sessions. And so this is a scale that is completed based on listening to an audio tape of a session. And it has the advantage of being able to provide the clinician, if it's reviewed by an experienced IMR trainer, with session-specific feedback about particular behaviors, skills, things that they did. For people who have ever received such session-based feedback from like audio sessions, you know how useful it can be because you can get into nuances or details of the interaction that you might not otherwise be able to get into. I think that is a very useful fidelity scale when you're able to get that specific feedback and when you're able to invest a little bit more in the individual training of clinicians. This is something that could be done by an experienced supervisor or an external trainer. I talk about some of the things that are the challenges or the things to try to focus on in particular for clinicians implementing IMR. One thing, of course, is the linking of the skills and the information being taught to individual goals. When you have a group going, it's a little bit challenging to link everything to every individual's goals. And so you end up doing a little bit of linkage here, a little bit of linkage there. The other thing that we try to do is to make sure that each person gets some focused attention on follow-up on their goals every few IMR group sessions. Unless you have extended sessions, it's hard to follow up on everybody's goal in every session. And so what you can do is you can keep track of the progress that individuals are making and who's being followed up in group by rotating whoever talks about their goals and making sure you get back to each person every, say, 3 or 4 sessions. That doesn't mean that their goals don't come in more frequently when talking about or helping a person make a connection between information and skills. But it does mean that you have a kind of a more formal review of where you're at, as well as being able to get input from other group members in terms of dealing with particular obstacles or challenges. Something that clinicians quite naturally find always a little bit more challenging is the use of the cognitive behavioral strategies, and in particular, looking for opportunities to do role playing, to provide specific feedback and things like that. The educational materials are, of course, very user-friendly, and it's easy to spend much or the whole session on psychoeducation. And I think psychoeducation is very important, but I think that looking for opportunities or planning in advance for role plays, for active practice of particular skills and things like that, breaks up some of the I don't know, you could say the monotony of the group, as much as I hate to use the word by myself, but it can make it fun. It can draw people's attention, and some people learn a little bit better from role playing practice, observing, and things like that. So I think attention to in particular the cognitive behavioral strategies. Sometimes the motivational stuff, when people aren't a little bit sure, you're always trying to link motivation in terms of particular goals. That can be important. If I was to say the one area which is most consistently a little bit short of when it comes to fidelity for IMR, I would say it's the integration and the getting of social support from other people. This can include the treatment team. I mean, you want the treatment team to be aware of the person's goals as well as aware of their participation in IMR and supportive of it. But ideally, you want family members or some other kind of significant individuals to know. And it's fairly consistent across different agencies implementing IMR that the integration with significant others tends to be kind of the lowest of the IMR ratings. And I actually think that you could take the curriculum of IMR and use it to develop a relative support group as a kind of a family psychoeducation. But even in the absence of that, a concerted effort to find out who are the support of other people. Are there ways of connecting with those people, perhaps sharing handouts and the like? I think those are important, especially because significant others don't always support individuals' goals. They may have beliefs. Somebody may want to get a job, but a significant other knows that they had a relapse in the last job they had, or they first became ill during school and the person wants to return to school. And there's this sense that getting a job or returning to school are stressful without the recognition that now the person is learning different skills for learning how to manage their illness, that these are important life goals. They give a person a sense of purpose, and then actual engagement in structured activities such as work and school has the potential to reduce rather than increase vulnerability to relapse. But you need to tap and kind of explore people's connections with support of others, the degree of support they have, and look to reach out in one or another way to both help them become more educated about the nature of the illness and the principles of its treatment, as well as the consumer's goals.
And Kim, that leads into another question that someone asked, to focus a little bit on youth, but also that idea of family. Like, are there any already developed adaptations for engaging family members or teaching it to family members? And is there any movement toward more of a youth-oriented IMR?
In terms of family adaptations, there are guidelines, and I don't know that they've been published, but I can send them. There are guidelines that Susan and I have created, just fairly brief guidelines for running essentially a family psychoeducational support group organized around the curriculum of IMR. I'm not aware of any research that's been done on it, but I've done a lot of family psychoeducation myself, and of course the curriculum lends itself to that. But that is something that certainly could be a starting place. In terms of IMR for younger individuals, IMR has certainly been done with younger individuals who could be said to have a serious mental illness. I would say late teens and early 20s. Because some of the terminology is different, because you often wouldn't make diagnoses for these different disorders for people under 18 or certainly under 16. I'm not aware of a lot of concerted work in terms of adapting it for younger populations, with the exception of, if we're talking about first episode psychosis. So these are individuals who have developed a psychotic disorder, but it is not a mood-related psychotic disorder. So it could be schizophreniform disorder, brief reactive psychosis. As people probably know, there's been a huge movement towards developing and implementing what are often described as coordinated specialty care programs for people with a first episode of psychosis. And the idea being that the first time psychotic symptoms manifest themselves, and sometimes people don't get into treatment for those symptoms for many months or occasionally even years, this represents a unique and important opportunity to try to improve the long-term trajectory of a serious mental illness by providing optimal treatment, optimal and comprehensive treatment from the get-go. And so one of the coordinated specialty care programs that was developed over the past 10 years is one that Susan Gingrich and I were both very much involved in. And this is called the Navigate program. The term navigate, or the name Navigate, doesn't stand for anything, although it does reflect a comprehensive program aimed at helping people both navigate the confusing nature of a psychotic disorder, as well as the almost equally, if not more so, confusing nature of the mental health system towards recovery. Now, all coordinated specialty care programs contain 4 different elements. They provide pharmacological treatment, although if the person doesn't want it, they're not forced to take it. You always try to provide as much as what the person wants and needs at a particular time. But you have pharmacological treatment, individual treatment, which is done either in individuals or in groups, family-based intervention, and then 4th one being supported employment and education. So in the Navigate program, which we were involved in developing, the individual component is called individual resiliency training. And individual resiliency training is really based on the IMR program, but shifted around in order to focus more on resiliency-oriented skills, in order to provide some unique components like steps for processing the experience, the often traumatic experience of developing a psychotic disorder or treatment experiences that may be related to that, which can lead to PTSD-like reactions, and that can interfere with participation in treatment and quality of life. And so the individual resiliency training program, similar to the IMR program, provides information about the nature of the psychotic disorder, certain things about principles of treatment, stress reduction strategies, resiliency aimed strategies, really with the purpose of enhancing quality of people's lives and the affective appreciation of things around them. We actually know that the experience of anxiety and depression is more or less independent of the experience of positive emotions, love, warmth, acceptance, spiritual emotions, and things like that. And that we can both teach people strategies for coping with negative emotions, but we can also we can seek to enhance their experience of positive emotions. So the Navigate program in IMR contains many of the topic areas that are in the IRT program in Navigate contains many of the topics that are in IMR, but there are also many other topics, and it's organized a little bit differently. There's a standard module, and then there is an individualized module. So the goal is most people get the standard module, but if the person has specific individual needs, you go into the individual module. And I bring up Navigate because Navigate was the first episode psychosis program that was rigorously evaluated in a cluster randomized controlled trial with 34 sites randomized to either Navigate or usual care, and then regular follow-ups every 6 months for 2 years. And that showed that the Navigate program outperformed the other program in a wide range of different outcomes, including psychosocial functioning, quality of life, symptoms, and depression. Interestingly, one finding that it's not even been reported yet, but we just saw it, is that it increased insight significantly more. And that's gotten me to wondering whether whether maybe one of the greater effects of IMR is on increasing insight and awareness of one's mental illness. Most recently, there's now 5-year outcome data showing that many of the benefits are actually retained 5 years later, 3 years after people began to go back to receiving usual services.
So another question, there's a fair number of people on the Zoom that work in our state forensic hospitals, and questions kind of about people who are in treatment for long-term and mandated treatment, and maybe hypothetically there's attending IMR is required, or and they get IMR when they're in maximum security hospital, and then they get transferred to minimum security hospital and go through IMR again, and then they're outpatient but still under, and have, so how do we keep things from getting, like you said, monotonous, or, kind of keep it fresh for people? Or what are your thoughts on sometimes when people are in treatment for long spans of time?
Right. Well, I think that, first of all, having a recognition that people may be familiar, and if you're working with people who indeed have some familiarity with it, I would adapt the teaching style of it, especially if let's say you had a mixed group of people, some who were familiar and some who were not familiar with it. I would definitely lean on the people who are familiar with it to help in terms of the teaching of some of the information to the other people. At the same time, I think we all know, anybody who's looked at the handouts and so on to the IMR program, that it's not something that people are going to necessarily master the first or the second or the third time. Plus, the relevance of certain kinds of skills or topic areas may only be apparent at a particular point in somebody's recovery. And so I think we have to have a kind of a healthy, open mind about the potential of IMR, as well as the potential as people are working towards different goals at different stages of their lives to continue to be relevant to people, while at the same time recognizing that they may have been exposed to the information, they may have much of it down, looking at that as a strength that the individual has, not kind of talking down to them so they need to learn it again, but rather looking to see if there are new insights from it, if there are particular areas of need that can be identified from it, and taking that that kind of understanding that the person has been through it again before, but at the same time, the meaning that it could have a new relevance at any point as a way of kind of going forward in a collaborative sort of way.
And from the research, do we have any idea if there's sort of like a range of this many modules or this many sessions to get a benefit, or when you go beyond this, you kind of like, it's a wash?
Yeah, I don't think so, partly because I think it really has to do with so many things like the style of teaching and things. You know, one example, you know, how I talked earlier in terms of saying about how IMR has been adapted in so many ways, and advantage is that it increases uptake, but a disadvantage is that it decreases control. Well, there's a group of people in Ohio since very, very early on in the mid 2000s, 2005 or 6, that took IMR. They decided it was too long. They were going to turn it into a 12-week program. And they have done IMR for 10 plus years as a 12-week program. Now I look at it and I go, well, geez, 12 weeks, you know, you're only getting a third of the curriculum. But then I've seen outcomes that show people benefiting from the 12 weeks. And so I think it's one of these things where as long as you try to be realistic in terms of the number of sessions you have and where you're at and what people can gain, that longer and shorter doses of it can both be beneficial.
And so I feel like so many of these questions, it's hard to know where to go next because like they interrelate so much. As people do some of those adaptations, that was one of the questions, is how at what point do you sort of lose fidelity when you're kind of adapting, and you know what it
right
is that?
Well, I mean, first of all, one could, in a very mindful sort of way, adapt IMR to turn it into a somewhat different program and kind of develop, you know, their own fidelity outcomes, which might be a completely defensible thing to do. So there's no kind of corner of the market on fidelity, so to speak. I think that you could do a lot of adaptations to the program. I think that to me, at the heart and the soul of the program is that people set goals. They break them down into smaller steps. They work towards achieving those goals. And in the process of doing it, they learn about their psychiatric illness, and they learn both information and skills for managing it. If I see an IMR program and it is not covering the breadth of different topics, unless we're talking about a kind of a unique adaptation, like we're talking about a component of IMR in a 2 to 3 week inpatient stay, where it doesn't make sense to teach the full range, or you need to have multiple different IMR groups. If you see an IMR program and they're not tapping the full range of the different areas, to me, that's a problem. I think if you're doing IMR and you are doing it in a purely psychoeducational format, to me, that is going to limit the impact of the teaching, but I still think there would be benefit, because I think that there is so little standardized information out there, and there's so few mental health professionals who are willing to be honest and just to talk about it. It's not my preference to see a purely psychoeducational intervention. I kind of think that the effects might be a little bit weaker, but I still think that there would be a significant benefit. One more kind of example. New York State took the IMR program, and they have a tendency to take standardized programs and they make them their own through standardization and things like that. And they did a really good job of standardizing everything, but they really took out the individual goals. And the person sets a goal for each session, but they don't have a long-term kind of a recovery goal. And both Susan Gigerich and I, when we saw it, we were kind of unhappy about that. And we continue to be a little bit unhappy about it. On the other hand, it's been in place in New York. I'm sure if people are engaging people in the program, it's probably helping them. I kind of feel you lose a little bit of the heart and soul of IMR when you don't have those goals. But it's also an example. In my older years, I've become a little bit less demanding that everybody, meet all of the check boxes, and kind of recognizing that there's different strokes for different folks, so to speak.
Great. And I was just alerted that Amanda, our other panelist, I think had something that you wanted to add, Amanda.
Yes, actually, on on going through the program multiple times. I have been through IMR multiple times. And as a person that's gone through it, I actually learned more each time, because the first time you go through it, kind of at a state of loss, or at least I was, that you don't really know anything about yourself. So going through it again is helpful to being able to focus really in on those, especially the first part of IMR, because once you get all the way through the program, that first stage of when you're entering into this is kind of not quite all sunk in. And so when you go through it again, you or me, I should say, I found that I was able to learn even more the second time through. And there were some things that I struggled with more than others. So going through the program more than once helped me narrow in on those particular areas that didn't get fixed right away, or I wasn't able to cope with right away. So it does help, actually, if you're going through this program more than once, to be able to focus in on your own individual goals as you learn more about yourself.
Yeah, that makes a lot of sense. Thank you for adding that.
Okay.
I just want to check in real fast with Kara. We have a lot more questions. I'm ready to go. Do you want me to keep going, or?
Yeah, we got about 5 more minutes.
Okay, awesome.
4 now.
I wondered about Kim or any of our other panelists, Amanda or Colleen, if you have thoughts on, or if there's research to sort of show that IMR is really useful in increasing people's participation in treatment overall and other areas of their treatment?
I think that's a great question, and I think that it is definitely worthy of research, and I do not know the answer offhand. My guess would be that it does increase participation in other areas of treatment. We've certainly seen it increase enrollment in supported employment, and we've also seen an increase in enrollment in consumer-operated services. One of the interesting things is that when we first started implementing IMR, we met with a lot of resistance, especially in inpatient settings, from psychiatrists who were very worried that the education we were providing about medication and the list of pros and cons of taking medication versus not taking medication would lead people to decide that they didn't want to take medication. And we were told on any number of occasions that you couldn't give people the choice of not taking medication, even though it's pretty clear that many people are already making that choice. But what we saw was that over time, these psychiatrists, because we've always involved them in the trainings, and we've always stressed the importance of collaboration between people providing IMR and the rest of the treatment team. And you want the psychiatrist knowledgeable when somebody is learning about the medication, that it invests people in their pharmacological treatment. They start coming back with more questions, they're more informed, they're more interested. And so we've gotten very positive feedback in that way. So I think it has the effect of increasing either buy-in or engagement in pharmacological treatment as well as those others. I think it would be interesting to see if it led to other increases in treatment.
And we also had a question about your thoughts about like group membership and mixing groups maybe with people who had a variety of sort of maybe some co-occurring developmental disabilities, or people who had much more severe mental illness or were much more symptomatic, and people who were less so, and your thoughts on keeping groups like similar or mixing groups.
Right. In general, the guidelines around group membership and in terms of skills training or IMR groups have suggested that if you can have people who are functioning at somewhat more similar levels of functioning, that there are some advantages to that in terms of the pacing and things like that. At the same time, you don't always have that luxury. And I think we also know, especially, for example, for people with developmental disabilities or intellectual disability, sometimes if they're not going to get served within a more general group, or a group serving a more general audience, they're not going to get served at all. So I think that, when you have the choice, being able to have people at more similar, functioning levels is preferable, but it's not an absolute requirement. And so I think some of the things that you try to do when you have people at varying levels is to count on some of the either higher functioning or better, better equipped individuals to help the people who have somewhat lower levels of functioning learn the information, to use them as practice teachers. It doesn't mean that they're not learning. They're certainly learning, and each person is kind of learning from the baseline that they begin. But rather than just trying to please everybody, trying to actively enlist some of the higher functioning people in helping you teach some of the things to some of the lower or helping them practice it and so on. I think that can be important. And then at the same time, I think it's important to figure out, okay, the people who are functioning better, what are their real needs? What are the ways in which their illness self-management can be furthered significantly, to do some real thinking about the individual tailoring and the needs that they have, or particular additional strategies in order to make steps towards their goals, so that you're not leaving them out, and you're not just thinking of them as helpers, but you're really thinking in terms of making sure that the group experience is something that is positive for them and they learn something. Being in the role of both teaching and learning can be very reinforcing for individuals, but you just want to make sure that each person is gaining in terms of their own illness self-management.
Thank you so much, Kim. I think we're maybe at a stopping point, Kara, so, okay, thank you.
Yeah, I think that sounds great. Thanks so much, Julie. And I just wanted to thank Dr. Robert, sorry, not Dr. Robert Myers, that was our last one. I just want to thank Dr. Kim Muzer and Colleen and Amanda and our hosts and attendees for a wonderful event today. We want to make sure that learning and practice does not stop here. So please check out the resources we have emailed, and do not hesitate to contact the Center of Excellence for more information on further customized trainings, mentoring, or consultation at your agency. Colleen has told us she is open to the potential of providing IMR trainings to other agencies. So if you or your agency is interested in practicing IMR, please let us know. We have recorded the event today and we'll send it out soon. For those of you who registered for CEUs, please fill out that form. If you are unsure about the process, please email Kizzy or myself, and do not hesitate to reach out to us for further questions. Like I said, we have emailed out the PowerPoint for today and a resource guide, and have recorded today's event. It will go out on our various social media platforms. So if you happen to not get the email with the resource guide or the PowerPoint, sometimes it gets blocked due to your company or agency's email restrictions. So you feel free to outreach to one of us, and we'll send that on over. If there's no more words from anybody else, I think that's all we have for today.
Thank you.
Thank you once again, Kim and Amanda and Colleen, and everyone who's been a part of this. Appreciate all the great information and thoughts.
Thanks for having me.
Yep.
Thank you.
Take care.